So the issue of what to choose to the patient who's coming to see you as a physician with this diagnosis is an important and an interesting one um, for the following reasons. Um, Historically, age has been the discriminator between what do we offer patients. So if you're 40 years of age or younger and you have a histocompatible sibling donor, stem cell transplantation should be offered up front. Now, most people will not have a matched sibling donor. It's only 1 in 4 chance per sibling. So the majority of people in the world don't have an HLA matched sibling donor. So immunosuppressive therapy is for those patients who are either over the age of 40 or don't have a matched sibling donor, which ends up being most patients diagnosed with this disease. Now, we have done a lot of work and a lot of laboratories have actually added enormous amounts of contribution to the understanding of the biology of severe aplastic anemia in terms of genes, telomeres, other risk factors, but they have not been consistently linked to outcomes across studies, especially the genomics data. It's not that predictive in terms of outcomes. So they have not been incorporated into treatment algorithms. So still today, we're still using just age and the availability of a donor in order to make those decisions. We're hoping that in coming years, more information will be added to this decision making. But as of now, this is the current paradigm, and this is what we're doing in 2018. Not everybody responds to immunosuppressive therapy. So 60 to 70% of patients respond. So that gives you about 30 to 40% of patients who will not respond. So now at 6 months, you may end up having a situation where somebody has not responded, meaning that their counts have not improved. They're still low. They still meet criteria for severe aplastic anemia, and they're likely getting transfusions still. So these are unresponsive patients. Now, the options for these patients are actually very, very broad. There's no randomized trial comparing all these treatment modalities, but you do have lots of options. So if somebody's younger and they do have a matched unrelated donor, that would be an option to go to transplant. If somebody's at 20, 22 and they don't have a matched sibling, but they had a matched unrelated. So it's important to look for these unrelated donors at the time you're treating some of these younger patients with immunosuppressive therapy in case at 6 months they turn out not to be responsive. So that might be an option. Historically, we also have repeated immunosuppression, meaning that we gave a second round of immunosuppression. So if somebody got a horse ATG, we have treated several patients with rabbit ATG as a second course, or elintuzumab, or even repeating the same horse ATG. Responses are variable there between 30, 40%. So a third of patients actually can respond a second time around if they have not responded the first time around with similar immunosuppressive agents like a second course of therapy. Now, why some patients respond the second time around and they don't respond the first time, it's not entirely clear. But some of these responses the second time can be very robust. Patients go on to develop normal counts, transfusion independence, and go well for a long, long time. So this is something that has been done. Continuing patients on cyclosporin is of limited benefit. It's not something that we think is actually helpful. It may add to toxicity long term. Androgens is interesting because androgens historically have been used in aplastic anemia for not only in aplastic anemia, for many diseases. And in unselected patients, we don't know what's the efficacy of androgens. We think it's about a third, but we don't know. Now, in patients with telomeropathy or telomerase gene mutations or some disorder in the telomere system, we published 2 years ago that androgens can actually be quite effective. Like 70 to 80% of patients have showed response to androgens in that setting. Now, growth factor support, we think, is also of limited benefit. What has come along in the last 7 years about is eltrombopag, which was used initially for refractory patients, just like the scenario that I just showed you, a 22-year-old who got ATG cyclosporin, did not respond, doesn't have a donor. Eltrombopag was investigated in that setting, and about 40 to 50% of patients responded to single outpatient, single agent oral outpatient regimen like an Eltrombopag. And some of the responses were multi-lineage, meaning that the hemoglobin went up, neutrophil counts went up, even though the study was designed to have the platelet count go up. So that showed that we were probably stimulating some very primitive stem cell compartment by giving this agent, a thrombopoietin receptor agonist.